Cognitive Behavioral Therapy for Eating Disorders. Rebecca Murphy, Suzanne Straeble, Zafra Cooper, Christopher G. Cognitive Behavioral Therapy. Eating Disorders. Anorexia nervosa. Bulimia nervosa. The eating disorders provide one of the strongest indications for cognitive behavioral therapy, CBT. Two considerations support this claim. First, the core psychopathology of eating disorders, the overevaluation of shape and weight, is cognitive in nature. Second, it is widely accepted that CBT is the treatment of choice for bulimia nervosa, and there is evidence that it is as effective with cases of eating disorder not otherwise specified, eating disorder NOS. The most common eating disorder diagnosis. This article starts with a description of the clinical features of eating disorders, and then reviews the evidence supporting cognitive behavioral treatment. Next, the cognitive behavioral account of eating disorders is presented and, last, the new trans-diagnostic form of CBT is described. Eating disorders and their clinical features. Classification and diagnosis. Eating disorders are characterized by a severe and persistent disturbance in eating behavior that causes psychosocial and, sometimes, physical impairment. The DSM-IV classification scheme for eating disorders recognizes two specific diagnoses, anorexia nervosa and bulimia nervosa, BN, and a residual category termed eating disorder NOS. The diagnosis of anorexia nervosa is made in the presence of the following features. The overevaluation of shape and weight, that is, judging self-worth largely, or even exclusively, in terms of shape and weight. This has been described in various ways and is often expressed as strong desire to be thin combined with an intense fear of weight gain and fatness. The active maintenance of an unduly low body weight. This is commonly defined as maintaining a body weight less than 85% of that expected or a body mass index, BMI, weight kg/height M2 or weight lb/height N, 2 × 703 of 17.5 or less. Amenorrhea, in postpubertal females not taking an oral contraceptive. The unduly low weight is pursued in a variety of ways, with strict dieting and excessive exercise being particularly prominent. A subgroup also engages in episodes of binge eating and/or purging through self-induced vomiting or laxative misuse. For a diagnosis of bulimia nervosa, three features need to be present. Overevaluation of shape and weight, as in anorexia nervosa. Recurrent binge eating. A binge is an episode of eating during which an objectively large amount of food is eaten for the circumstances, and there is an accompanying sense of loss of control. Extreme weight control behavior, such as recurrent self-induced vomiting, regular laxative misuse, or marked dietary restriction. In addition, the diagnostic criteria for anorexia nervosa should not be met. This trumping rule ensures that patients do not receive both diagnoses at one time. There are no positive criteria for the diagnosis of eating disorder NOS. Instead, this diagnosis is reserved for eating disorders of clinical severity that do not meet the diagnostic criteria of AND or BN. Eating disorder NOS is the most common eating disorder encountered in clinical settings, constituting about half of adult outpatient eating disordered samples, with patients with bulimia nervosa constituting about a third, and the rest being cases of anorexia nervosa. In inpatient settings, the great majority of cases are either underweight forms of eating disorder NOS or anorexia nervosa. In addition, DSM-IV recognizes binge eating disorder, BED, as a provisional diagnosis in need of further study. The criteria for BED are recurrent episodes of binge eating in the absence of extreme weight control behavior. It is proposed that BED be recognized as a specific eating disorder in DSM-V.6. Clinical features. Anorexia nervosa, bulimia nervosa, and most cases of eating disorder NOS share a core psychopathology, the overvaluation of the importance of shape and weight and their control. Whereas most people judge themselves on the basis of their perceived performance in a variety of domains of life, such as the quality of their relationships, their work performance, their sporting prowess, for people with eating disorders self-worth is dependent largely, or even exclusively, on their shape and weight and their ability to control them. This psychopathology is peculiar to the eating disorders and to body dysmorphic disorder. In anorexia nervosa, patients become underweight largely as a result of persistent and severe restriction of both the amount and the type of food that they eat. In addition to strict dietary rules, some patients engage in a driven form of exercising, which further contributes to their low body weight. Patients with anorexia nervosa typically value the sense of control that they derive from undereating. Some practice self-induced vomiting, laxative and/or diuretic misuse, especially, but not exclusively, those who experience episodes of loss of control over eating. The amount of food eaten during these binges is often not objectively large, hence, they are described as subjective binges. Many other psychopathological features tend to be present, some as a result of the semi-starvation. These include depressed and labile mood, anxiety features, irritability, impaired concentration, loss of libido, heightened obsessionality and sometimes frank obsessional features, and social withdrawal. There are also a multitude of physical features, most of which are secondary to being underweight. These include poor sleep, sensitivity to the cold, heightened fullness, and decreased energy. Patients with bulimia nervosa resemble those with anorexia nervosa both in terms of their eating habits and methods of weight control. The main feature distinguishing these two groups is that in patients with bulimia nervosa, attempts to restrict food intake are regularly disrupted by episodes of objective binge eating. These episodes are often followed by compensatory self-induced vomiting or laxative misuse, although there is also a subgroup of patients who do not purge, non-purging bulimia nervosa. As a result of the combination of undereating and overeating, the weight of most patients with bulimia nervosa tends to be unremarkable and is within the healthy range, BMI equals 20 to 25. Features of depression and anxiety are prominent in these patients. Certain of these patients engage in self-harm and/or substance and alcohol misuse and may attract the diagnosis of borderline personality disorder. Most have few physical complaints, although electrolyte disturbance may occur in those who vomit or take laxatives or diuretics frequently. The clinical features of patients with eating disorder NOS closely resemble those seen in anorexia nervosa and bulimia nervosa and are of comparable duration and severity. 7. Within this diagnostic grouping, 3 subgroups may be distinguished, although there are no sharp boundaries among them. The first group consists of cases that closely resemble anorexia nervosa or bulimia nervosa but just fail to meet the threshold set by the diagnostic criteria. For example, binge eating may not be frequent enough to meet criteria for BN, or weight may be just above the threshold NN. The second and largest subgroup comprises cases in which the features of NT and BN occur in different combinations from that seen in the prototypic disorders. These states may be best viewed as mixed in character, and the third subgroup comprises those with binge eating disorder. Most patients with binge eating disorder are overweight, BMI equals 25 to 30, or meet criteria for obesity, BMI greater than or equal to 30. The empirical status of cognitive behavioral therapy for eating disorders. Consistent with the current way of classifying eating disorders, the research on their treatment has focused on the particular disorders in isolation. Wilson and colleagues 8. have provided a narrative review of the studies of the treatment of the 2 specific eating disorders as well as eating disorder NOS, and an authoritative meta-analysis has been conducted by the UK National Institute for Health and Clinical Excellence, NICE. This systematic review is particularly rigorous and, as with all NICE reviews, it forms the basis for evidence-based guidelines for clinical management. The conclusion from the NICE review, and 2 other recent systematic reviews, is that cognitive behavioral therapy, CBTBN, is the clear leading treatment for bulimia nervosa in adults. However, this is not to imply that CBTBN is a panacea, as the original version of the treatment resulted in only fewer than half of the patients who completed treatment making a full and lasting recovery. The new enhanced version of the treatment, CBTE, appears to be more effective. Interpersonal psychotherapy, IPT, is a potential evidence-based alternative to CBTBN in patients with bulimia nervosa, and it involves a similar amount of therapeutic contact, but there have been fewer studies of it. 11.